And then review conditions where insulin adjustments may be required. So when we talk about glucose goals and ranges, targets, they're both a little bit different. So we have a goal range, and then we have a specific target that might be very individualized to that specific student. The number, when we talk about target, the number that defines when to start calculating a correction dose, if, like, say above 120, or for our littles, maybe above 150. And when you look at the diabetes medical management plan, you'll see that listed, like what is that student's target? Typically it falls between 100 and 150. However, most of the time it's 120. If they're on an insulin pump, you might see their pump with a target that has a lower number. But generally speaking, most kids have a target of 120. The correction insulin dose is designed to bring the glucose level back to the target. So for example, like if using an insulin pump connected to a CGM, which is a continuous glucose monitor, or a sensor, Dexcom, Freestyle Libre, Guardian, whichever sensor that they're using, the automated insulin delivery system, or the AID, or the insulin pump, that algorithm that's programmed in that pump linked with that CGM is working to bring the glucose level back down to that target. You can see down at the bottom, Shannon put in a lovely picture about how that works. So that orange line is the customized target glucose goal, and then the dotted purple is kind of what the glucose level is kind of throughout that day. So for students who wear continuous glucose monitors, again, it's usually worn. A lot of times they have it on the back of the arm. Sometimes they have it, other places. Callie's gonna talk a lot about the pumps and CGMs in greater detail. But when we see them in the office, or when we are looking at their data, maybe the mom or you guys call and say, hey, like, little Johnny's blood sugars have been running really, really high. Can you look at the data? Whether that's pump data, CGM data, glucometer, whatever. What we're looking at is what is that child's target, what is their range, how much time they're spending in range. Ideally, that time in range, we have that goal of greater than 70% time in range for most of the kids. That's usually a blood glucose level of like 70 to 180. Time below range, or like below 70, we would like to limit that, because obviously that means that they have those lower blood sugar levels. Less than 70, ideally less than 4% of the time they're spending in that range. Less than 54, again, that's a severe low blood sugar level. Ideally less than 1% of the time they're spending in that range. So of course, like, the higher percentage of that time in range, the better. It's great. And we see a large spectrum of the time in range for a lot of kids. Time above range, greater than 180, ideally we'd like to see that be about 25% of the time or less. And above 250, again, that above 250 range is when we start talking about checking for ketones. Are they sick? Is there a problem with their pump? Like, what is going on that their blood sugar is that high? Ideally, when we're looking at that overall big picture, what is that percentage of time that they're spending in that range? And our goal is that they spend less than 5% of the time in that range. When you have a student who is on a continuous glucose monitor, you can actually see this information sometimes if they use like an app or something like that, or maybe the parent looks at this information, and it's really helpful for us to kind of gauge what adjustments might need to be made. whether it's to their insulin dosing or behaviors or further education, whatever is needed. So this is a big assessment piece for us that we use a lot. General goals for students who monitor by a glucometer, that's like a finger stick blood glucose check. Obviously we want to check that blood sugar fasting or pre-meal, and that ideal range is 80 to 130. Sometimes, we have documentation that says like 70 to 150, maybe a little bit more of a reasonable range. Post-meal glucose, like if we're checking a child after they've eaten within that 2-hour window after the start of the meal, we're looking for them to be ideally less than 180. Before exercise, the goal would be like 126 to 180. One thing I would mention here is to have that discussion with a parent. Maybe their child exercises and drops really fast, like exercise is a big piece of a kid's day, recess, things like that. You also want to have that discussion with the parent on their individual child's blood sugar pattern. The hemoglobin A1C, is everybody familiar with what a hemoglobin A1C level is? Okay, so for those that are not familiar with the hemoglobin A1C level, it is a measurement, like a blood test that we can do that will give us the average of what someone's blood sugar has been over the prior 3 months. We check the A1C generally with every visit as long as it's been 2 or 3 months, and that kind of gives us an idea of their blood glucose management and how well they're doing on that goal. So, for example, like the average blood glucose of 154 over the past 3 months, it gives us that average in a percentage. So this kind of puts that piece together. This is the International Society of Pediatric and Adolescent Diabetes consensus guideline. So in the middle there, you can kind of see what the finger stick blood glucose level would be. And on the left, you can kind of see where that time and range would be. So for example, like if they're spending time and their average is 180, that's going to translate to that higher end of the time and range percentage. And then on the other side, I can't really see that, Shannon, can you see that? Sorry. The A1C of 7% of the time is that higher level. So goal glucose ranges and targets, by meeting the glucose goals, there's a reduced risk for acute and chronic complications. I know Dr. Patel was talking about that a little bit this morning, like the better management and education that we can provide when they're first diagnosed and when they're younger, ideally will carry out through their life and reduce that complication risk. Goals should be individualized, and we should meet our students and our patients where they're at, because what might be possible for one child might not be possible right away for another. And so we always have to assess and reassess where that child and where that family is at. Focus on progress towards goals, like Shannon was saying earlier, like we want to make sure that we're providing that positive reinforcement to our students as much as possible, and identifying any barriers. Does this child and family have food insecurity? Do they have trouble affording their medications or transportation? It's those social determinants of health, education, reading levels, things like that, that might be a barrier to care, that if we're able to identify. That's where you guys come in, and you're a very valuable part of that care team, where if you know something about a barrier that's limiting their ability to care for their diabetes, or something that they're struggling with, don't hesitate to reach out and say, hey, like I've noticed this is happening, or I've talked to this mom and she's worried about this, can you maybe talk about it at the next visit? Because again, we don't see them as much as you guys do. So we definitely value your input and insight for those students. I'm gonna turn it over to Shannon to talk about the insulin sensitivity factor and the carb ratio.
Okay, so insulin sensitivity factor, or the correction factor, I feel like we call it that most often, tells how many points the blood sugar will drop for each unit of insulin given. So if you have a correction factor of 20, it means for every unit of the Humalog or the Novolog, whatever rapid acting insulin they're using, it's gonna drop their blood sugar by 20 points. Of course, this isn't a perfect science. It's just kind of a gauge, and we kind of have to adjust that over time as they're growing and their insulin needs change. But that's what that specific number is going to mean. We don't really, when you're on like multiple daily injections, we don't really do negative corrections. So if they're under their target coming into a meal, say they're 100 and their target's 120, I'm not going to figure out a negative correction dose. Some pumps will do that on their own if that's the settings that they have, but generally if you have somebody on injections, you're just gonna say, oh, if you're above 120, you're gonna need a correction in addition to your carb dose. At the bottom is kind of our shorthand way of writing it, 1 to 20 over 120 if that's a correction factor. And our carb ratio, again, it's a fluid number. It changes a lot during our visits, and we say, you know, you have 1 unit of quick-acting insulin for every X amount of carbs. And we kind of talked about earlier how for our older kids, that might be a smaller number, and for our younger kids, that might be a bigger number, but it will be on your diabetes medical management plan. I'm just gonna say DMMP to make it not such a mouthful. So when you're using your carb ratio, review all your sources of carbs for the meal or the snack, add up the grand total, and then you're gonna divide by that number, and in this case, it would be 10. All right, Juliet's gonna continue about our DMMP.
So the DMMP, or the school orders, as I mentioned earlier in the introduction, we're an American Diabetes Association accreditation program. And so we have a lot of, contact with the ADA. We, follow a lot of their recommendations. And so this year we've taken some time to kind of take in the feedback we've received from a lot of you that we appreciate, from parents as well, to also incorporate some of the changes that have been recommended by the American Diabetes Association. So the DMMP, or the Diabetes Medical Management Plan, or the school orders, is a document that we provide to the parent at the visit to give to the school, ideally. Sometimes it doesn't make it there. If it doesn't, let us know. We're happy to fax it. We can't text anything or things like that, but we are happy to fax it to you if the parent lost it, or they can't find it, or they just don't bring it in. It is a separate piece from that medical certification for chronic health conditions. I do want to make sure that we're aware that for you guys, that's kind of as 2 separate documents. What we've done this year is we've kind of incorporated the 2 into 1 at the beginning of the school year. And so our thought is every student with diabetes should have a 504 plan in place. That is recommended by the American Diabetes Association. It also is a great way for, when we were talking earlier about like how can we make sure that we talk about goals in between. That can be put in that 504 plan. Like, this is the parents' responsibility to kind of keep you guys updated on what the goals are, or how you contact our clinic. Though that meeting that you have on that 504 meeting is really important, because it sets expectations for the parent of, to communicate with you what their expectations are, and what you can communicate with them about what your capabilities or limitations might be. Because sometimes, we get phone calls and we're kind of in between, and our role is not to referee that. We're a resource. So again, the DMMP is the school order portion. How to care for the diabetes at school. What is their goal? What is their target? What is their insulin to carb ratio? What's their insulin to sensitivity factor? How often they need blood glucose monitoring, whether they wear a sensor. With the law that was signed into place in April by Governor Hobbs for cellular devices in the school setting, we have also incorporated to make sure that we have that in our school orders as well. Yeah, and again, that can also be part of that 504 meeting and that 504 discussion with the family. But we have incorporated that if we know the student has a cellular device or an automated insulin pump system that runs off of the cellular connection, that we put that into the school orders to add that the student does use that for a medical condition, because that's part of that law, because there's an exclusion for that. When we see the student before the school year, or for the first time since the school year started, or if we haven't provided, or they call and ask us for that medical chronic health form, the packet that you'll receive is the general information for caring for students with diabetes in school, their individualized insulin dosing plan, as well as that medical certification for chronic health conditions form. So you should see that all together in one packet. If, again, you don't see that, let us know. We're happy to provide that. It's, again, a very collaborative approach between us and the parent and you guys. If, for example, we see them and we've already provided them the packet at the beginning of the school year for that chronic health form, and maybe we updated insulin dosing for them, that is the document that you'll receive is just that change of the dosing. So it's a little bit smaller. So again, the initial DMP packet will provide recommendations for glucose monitoring and insulin dosing, hypoglycemia management, recommended level of support at school and individual care needs for students. And so maybe that's something that we need to discuss as a group of like, hey, can we put the goals that they're working on? Sometimes they're working on goals that aren't nutrition related. Maybe they're working on goals to go see the school nurse every day. Maybe it's to, exercise more or enter in all their carbs into their pump. That's a frequent one. And we monitor and assess those goals at every visit, and we change them. And when they meet a goal, we complete it and we move on to the next one. And we try to make sure that they're working towards their goals, and we try to provide that positive reinforcement and problem solving and things like that. So underneath the level of support, that's something new that you will see on the new school orders that weren't there before, and that's part of that ADA. I don't know if anybody has actually used, or maybe your school district is using the American Diabetes Association Diabetes Medical Management Plan form, but that was from the ADA. And so we look at, where is this student? Maybe they're 16, but maybe they really need full supervision at school. We're gonna put that on there. It's also a collaborative discussion with the parent or the guardian. Maybe they are totally independent, they are awesome, and they never go to see you guys at all. That is something that would be on there. And again, we do consider students, 8th grade or younger, that they do require supervision at school. Whether that is just supervision to make sure that they're giving insulin appropriately, that they've entered everything appropriately and correctly, calculations, things like that, all the way to total support you know, maybe it's a child, you know, with a developmental concern, or maybe they're little and they need that complete and total, care at school. Access to Wi-Fi and cellular devices, again, I mentioned that that's on there. Nutrition information, how to handle exercise and sports activities. I like to throw recess in there with exercise, because we all know the littles, they get morning recess, they get before school recess, they get PE, then they get after lunch recess, and maybe an afternoon recess, and sometimes they can go low a lot, with that multiple, times per day that they're active. It'll also discuss what to do when their blood glucose is high or they have hyperglycemia, and if they have ketones and when to check for ketones, and the recommended supplies and clinic contact information. I would like to reinforce to you guys, yes, we do go over what supplies they need in the school setting. We do talk about that at diagnosis and all the time. We make sure that we ask them, did you give your school nurse or health aide that, you know, glucometer? Do you have a non-expired glucagon or vaccine at the school setting? If they don't, our physicians will refill that medication. We do encourage them to bring snacks for their child to school. So it's not like you're like, yeah, you're on your own. We do talk about that a lot. So we get that question a lot from schools. So in continuation, when we're talking about the blood glucose monitoring, this is a snippet from the actual DMMP. So again, that overall target range, 70 to 180, and we're looking at monitoring whether they are on a sensor, whether they're on finger stick, using a glucometer. We're looking at that they're checking their blood glucose before they eat, whether that's maybe they have breakfast at school. They should be coming to see you, and then same with lunch and snacks. When they are feeling high or low, whether they have, if they have symptoms of a low blood sugar, or maybe sometimes the teacher might notice, oh, he's kind of acting a little off, or he's saying he's dizzy, something like that. They need to have that blood sugar checked. And I know Danielle and Monique are gonna talk about hypoglycemia a little bit later, but of course, I just wanna stress, if a child has low blood sugar, they should not be left alone to walk to see you guys by themselves, or with a small little buddy. Take a friend. Before PE and exercise, when the last glucose check is greater than 2 hours, before leaving school for school-provided transportation or after-school programs, they should have that checked. And then any other time that maybe that parent or guardian would like you guys to check that blood glucose level. Maybe they've been trending lower over the past few days. Maybe they, have a specific concern. That's that collaborative approach and discussion with the parent. When to check a blood glucose using a glucometer. So say, for example, if a student is using a continuous glucose monitor, a sensor, maybe you have the capability to monitor that child remotely from an iPad or something like that. Awesome. If you don't, and maybe they use a receiver, you want to lay eyes on that receiver and check to see where they're at. But sometimes maybe their symptoms don't match what that sensor is listing. That absolutely needs to be checked with a finger stick blood glucose for safety, as well as if the sensor reading is inconsistent or unavailable. Maybe their sensor expired, or maybe the Wi-Fi is bad at the school, whatever. If it's not consistent or unavailable, you want to check. If the sensor reading is less than 70 and you've treated for that low blood glucose level, and then you're rechecking that after 15 minutes, if that sensor reading hasn't really changed, you want to double check with a finger stick. Anytime the manufacturer recommends it, but the big thing is if their sensor readings don't match how they're feeling. So that's always best practice. When in doubt, check it out. Please discuss the type and brand of sensor and glucometer with the parent or guardian. With insurance changes and availability of products, sometimes that changes in between visits and we're not aware of it. So always just have that discussion with that parent or guardian on, what are they using right now? Or if all of a sudden they show up with something new, you're like, hey, what is this? And then please discuss with the parent or guardian if they desire the remote monitoring by the school of that CGM or that sensor reading. When we talk about the insulin dosing guidelines, sorry, I keep thinking that I'm gonna turn it over to Shannon. Try. Okay. So when we talk about insulin dosing on that diabetes medical management plan, we list out the insulin to carb ratio and the time. So earlier you heard from Shannon and Jackie that they might have multiple time segments. Some students have breakfast at school. Some are only there for a half day. With the insulin pump users, they do a lot. It's really common for them to have multiple time segments and different carb ratios or different correction factors based on the time of day. So you might see, just one line. Maybe they have the same carb ratio all day, or maybe they have 4 or 5. So it's very individualized. And so we did change this a little bit this year to kind of make it a little bit easier for you guys to read, that list out those different time segments for you. So it's gonna be, bolus before meals and snack, and calculate the dose by dividing that total grams of carb by the insulin to carbohydrate ratio below. We also listed all of the rapid acting insulins at the top. And then we also talk about the correction factor, that insulin sensitivity factor, and it's broken down again by time, and then 1 unit of insulin for every 50 points over 120, over 100 points over 120, every 20 points over 120. It's definitely individualized to that student. Additional considerations, correction bolus for glucose levels above target should be given no sooner than 2 hours from the last dose of rapid acting insulin. If they are on a insulin pump that's got a continuous glucose monitor, or like a smart pen device like the InPen that they might be using that has that bolus calculator, if again, have that discussion with the parent. But you can follow, say for example, like it hasn't been that full 2 hours, if the recommended you can recommend to follow the doses determined by the bolus calculator in the insulin pump, because it gives small doses throughout that daytime. It looks at the insulin that the child already has on board, and the algorithm is looking at what their blood glucose levels kind of predicted to be. And you'll learn a lot more about that during that insulin pump section later. Correction doses should be based on the glucose levels before eating, so thank you guys for getting that beforehand. Because some students, especially the littles or maybe kids with developmental delay, might be giving insulin after they eat. I do want to mention again, that collaborative practice piece of insulin dosing may change 20% above or below in between visits. Parents have the most up-to-date instructions for their students. If, however, there's a very large discrepancy from what's on the school orders, or you're really not thinking that what the parent is telling you might be a little off, or it's concerning to you, or you're unsure what to do, just reach out to us and give us a call. One of us is always in the office Monday through Friday, 8 to 4:30, and then we also have a physician on call as well that we can talk to. So if you don't already have our phone number, it's that 520-420-2212 phone number, and ask to speak to one of the diabetes educators or the physician on call if we're not available. in addition, when we talk about treating low blood sugars, again, Monique and Danielle are gonna go over that in greater detail later. But part of the DMMP is that glucagon administration, that rescue medication for low blood sugars, you know, that we would need to give this to a student, or you would give this to a student, if, you know, their blood sugar was low, if they're confused, if they're not able to swallow, you know, or, you know, they have that severe load that's, not able to be treated with, you know, food, juice, glucose tabs, gummies, whatever that student is bringing. So there are different types, and again, like Danielle's gonna go over this a lot in greater detail, but there's the Gvoke HypoPen, there's the Baqsimi, which is the yellow, and that's an intranasal product. There's the Red Kit Glucagon, that's been around forever, that most of you may have seen at some point. And then there's the Zegalogue. So those are the primary ones. And in our DMMP, we actually go through like what that dose is, because it can be age and weight based. So when I talked about supervision, again, this is a snippet from what that is gonna look like that you'll see on the new and updated school orders. And we individualize this based on our assessment and that parent discussion with our visits when we give them that school order is, you know, what level of supervision do we see that they might need in the school setting, and we're gonna put that. And it actually does list out for you what full support, supervised support, or self-care would look like. And then again, down in the bottom, those additional care needs. And our favorite, yes, they do use their cellular device for a medical condition. That was a big sticking point like last year at the end of the year, so we made sure to add that. And then again, the pump and the CGM type, if that's available. Okay, I'm gonna turn this over to Shannon to talk about the Beta Bionics, the iLet pump. It's a newer pump that you might start seeing if you haven't already seen. And she's gonna kind of go over the school care for students who use iLet, because it is a little bit different.
So as we were kind of revamping our school orders, we were trying to make one to encompass everything, and we realized like this, we just need a separate one for the Beta Bionics pump because it's so uniquely different. And so with that, if they're on the iLet pump, they'll get a unique packet that's just about the iLet pump, and then the follow-up, the shorter packet if we make any changes. It'll just have the most important points. We have a backup plan. There's no like settings with this pump, like you can't have a basal rate, a carb ratio, a correction factor. That's not how this one works. So when they are telling the pump that they're eating, they're announcing a meal. And it's off of, you know, is this a usual kind of breakfast for me? Is it more than, is it less than? Or is it such a small amount of carbs that I wouldn't even announce? That's not something that I would feel comfortable knowing. That's not something you all would probably know about that student. You're gonna need parental input. What is this meal? Like if they bring a lunch to school, would you consider this usual for them, less than, more than? Because you're not entering grams. You're just giving that information. So that's a hard discussion point. It's not difficult, but that's an important discussion point with families is they have this meal, how would this be considered? Because it's based off of their usual intake, which parents know best, right? Parents or guardians. The other point about this is that this particular pump does not respond well with late announcements. So they're educated. You can announce your meal up to 15 minutes before eating, but no more than 30 minutes. So if you had a kid that took an hour to eat, you're not gonna have them announce because it's just too late in the game for this particular pump. So timing is very important with this one. You could think of it in a numbers perspective, like if they usually eat 60 grams of carbs for a meal, maybe their more than is closer to 90, their less than is closer to 30, and then the do not announce is like 10 to 15. You can kind of think about it that way, but just to reinforce, they're not actually entering numbers. And those meal announcements are based on the carb content of the meal. So just really touch base with the parents on this one. If you have a kid who needs full support or supervision, you're gonna be involved with that process.
Could I ask the benefits of that from,
I think they'll probably have different perspectives on it, but a common one is that they are relieved of carb counting if that's not something that they were really big into. And they're not adjusting settings. The algorithm is already, you have to use it with the CGM. It's not something that you would wear separately. You have to have a working CGM with it. So it kind of reduces a little bit of that burden of care, and that they're not focusing on all these numbers. They're like, this is my usual breakfast. I eat it every day. Usual for me. Or I had half as much, less. So they aren't having to like hyper focus on those numbers.
what population is you in that?
The more like our middles to teens, the ones who are, I think we as a group kind of recommend this one for people who are experiencing burnout, because they just need a break from the micromanagement of it all. Our reps are gonna be all in the hallway, and we have the beta rep. They're all wonderful people, like very friendly. Please tap into their brain, because they work with these devices all the time and they can advise you very well. But yeah, typically like our teenagers who are burnt out.
Isn't this pump also unique in that it doesn't administer all of the insulin at once? Like it administers a certain amount and then later it's right? Am I correct in that?
The algorithm is like that. I think it does like 75% up front, and then it will add on the additional on its own.
If it needs it?
Yeah,
Yeah.
yeah. It's definitely different from all of our other ones in that it runs off of the algorithm and you can't really manipulate it, which is not bad. It's just different. Will have on the eyelet school forms, we will have the backup therapy plan. Say their CGM comes off, their pump breaks, we will have a plan there for if they needed to fall back on injections and carb coverage and correction. We will outline that for you so you have a place to move to. We're gonna do a little bit of some calculations practice for those who might be new to this arena. And we'll go over kind of rounding. We have a whole slide on that, and trying to be aware of our time for the next presentation. Say you have a kiddo who has 52 grams of carbs for lunch, and you know their carb ratio is a unit for every 15 grams. I take that total divided by 15, and I come up with the units. And we usually teach families, like especially who get overwhelmed with numbers, drop everything off after the 10th place. Call it 3.4, but you don't need to carry out all the numbers. And we don't round this dose yet because we still have to figure out the correction dose. Here is kind of a situation where we talk about calculating the correction dose. And it's based off of the target of 120, the correction factor of 20, and a blood sugar of 204. So our first step, if the blood sugar is higher than the target, we take the blood sugar and find how many points we are away from that target. We just subtract. Once you get that number, which would be 84, we're gonna divide by that correction factor of 20 and then come up with your units of Hume-Log. Again, this is an unrounded number. It's just what it is for right now. Once you have both of those pieces of information, then add it up and then round. So we'll talk about if you have kiddos who have the ability, and this is, the rounding part is for people who are using injections, not pumps per se. So say you have 7.6 units of Hume-Log that you calculate, we need to round that number. And the first question I would say to myself is, well, am I dealing with a pen that's capable of half units? Or is this pen just capable of whole units? Which you'll find littles have half units, our olders usually have whole unit pens. They just aren't quite as sensitive a lot of the times. So if that total dose ends in a 1 or a 2, I'm gonna round it down. So if I calculated out 1.2 units, that would round down to 1, and that's what I would give. If the total number ends in a 0.3 to 0.7, I would round to the middle if I have a half unit pen. And then if it ends in an 8 or a 9, I'm gonna go ahead and round that up to the next whole number. So 1.8 units would become the 2 units that I would give. If you have whole unit insulin pens, just follow your kind of normal rounding guidelines. If it's 0.1234, I'm gonna round down. 0.56789, I'll just round up. You have those sheets, those calculation sheets in your folders. If you just like to go through those steps. And this is an example of, okay, I have a kid whose correction is a unit for every 100 points over 120, and then a carb ratio of 1 unit for every 35 grams. If I check the sugar and it's 115, I know it's below my target, so I don't need correction. So I just put a 0 there. I don't go through all the steps and make a negative number. My carb dose, take the total, divide by 35, I get 1.1. Since the correction was 0, carbs are 1.1, my total is 1.1, and I would round that down to 1 unit and give the 1 unit. If you are an appy person, the T1D1 app was recently FDA approved for insulin dosing, so that's pretty amazing considering a kiddo with type 1 developed it. So that, I've had it on my phone for a long time, so I still have it, but I think if you try to download it now, it might not be ready until October. But keep that in mind as a good one, if you like that extra support in doing math, and you don't have a partner to kind of bounce off ideas from. Bolus calc, some of our families use. Anytime you use an app, just make sure the settings are correct, because you have to go in. If their carb ratio changes, you have to change it in the app. If their correction factor changes, you have to change it in the app. So just making sure that those are always correct settings. And then we'll go over kind of almost lastly, some unique situations that you might come across. We went over a couple of these already. If you don't finish your food, but you already have that insulin on board, try to find a replacement. Say somebody ate something from a friend, which is kind of a goal sometimes. Like, let an adult know before you eat your friend's food. And you don't know what they ate, we might just need to recheck in on the blood sugar in a few hours. Like, I can't count carbs that you ate and I didn't see, so let's just check in a few hours and see what's going on, and you might need a correction dose at that point. Party in a classroom after lunch, there's gonna be cupcakes. Go ahead and, based off of kind of our prevention of insulin stacking rules, if it's gonna be within that 2-hour time frame that they have the cupcakes and lunch, just dose for the carbs and the cupcakes. You're not doing another correction because it hasn't quite been the full 2 hours yet. Large discrepancy between what the paperwork says from us and caregivers are asking. 20% is kind of a leeway for that. Like, say they didn't give you the updated dosing, but we typically don't make adjustments that are more than 10 to 20%. But if you're seeing something like 30, 40% or something that just doesn't feel comfortable and it's not on your forms, definitely give us a call so we can realign everything. And then the situations, if we acknowledge that kids need dosing after meals, that should be a part of that DMMP, that should be stated in there. And again, you're just correcting based on the sugar before the meal and then whatever carbs they're eating afterwards and adding that total together. Does that feel comfortable, all of those scenarios? Okay. And you always have our phone number to call us during business hours if you need to coordinate some care, have some concerns.
before I turn it over to Monique and Danielle, because I know I'm very wordy, so we're running a little bit behind schedule. But I do want to mention in your folder, you have a list of resources as well as a handout from the ADA and Breakthrough T1D on Safe at School type of information. I really would stress you to look at these two main resources. They have a plethora of fantastic information and resources for parents, for schools, and for school nurses and health aides. They break it down even by state in some cases, so I would definitely encourage you to look at those sites. There's information for teachers as well. The ADA and Breakthrough both have really increased their advocacy for Safe at School for kids with diabetes over the last couple of years, and so they've added a lot of great information and resources for you guys. So that is listed in your packet right here, and there's also again that handout on ADA. So without further ado, I am going to turn it over to Monique and Danielle to talk to you guys about emergencies and hypoglycemia.
My name is Monique. Myself and Danielle are two of the RNs in the clinic. So I've been there a couple years now, and I came from the ER, so totally familiar with seeing emergencies in the ER due to diabetes. So we'll get going. We know you're probably getting tired, ready for lunch, ready to get moving. So we'll keep it short and sweet because this is something that we talk about on a daily basis in the clinic and that you see most often. So our goal is that you better understand, the treatment of highs and lows and ketones and how that process is working in the body. So hyperglycemia is defined by elevated blood glucose above 250. If there's anything different, it would be in the school orders, but usually 250 is the number we're talking about when we're talking about hyperglycemia. Some of the symptoms that we might see: very thirsty, peeing a lot, very hungry, sleepy, and then blurry vision. That can be when things are sustained highs for a while, and then affections or injuries that aren't healing. That's more of a long-term complication. And then some patients report having no symptoms at all, and these are mostly our patients who are used to running high most of the time. They just don't feel any different because that's their normal. Causes of hyperglycemia. The number one and most common is going to be late or missed insulin. So we're missing boluses. If they're on multiple daily injections, they're missing their Lantus, that long-acting background insulin. Maybe they're eating differently or more than planned. They see you, but then they have something in their backpack that they also want to eat, and that's not accounted for. Expired or improperly stored insulin can be a thing. Maybe they pick up prescriptions and they leave them in the car, for a while before bringing them into the office, or even devices. Sometimes we see on that second or third day that the insulin is not working quite as well as it did on that first day. Just having those devices exposed to the heat, especially in the summer. Illness or injury, of course, can cause glucose to be elevated. Stress, you're dealing with kids who are, maybe they're anxious or stressed about testing or relationships at school, and of course hormones that neither of us can control, so that's a factor. And then decreased activity, maybe they are an athlete and during some seasons they're more active and their blood sugars are lower, but now, for some reason they're not in sports or it's an off season, you might see that as well. And then sometimes, which is when we, can use that communication either from you or the parent, maybe these are consistent highs and they just need a dosing adjustment because kids are growing and insulin needs are changing. So the treatment, this seems long, but it's pretty straightforward. What are you gonna do when you encounter high blood sugars? So if you, if they're wearing a sensor and you suspect that glucose is not accurate for some reason or another, or you just want to be sure, it's okay to do a finger stick. And from there, if it's a sustained high for more than 2 hours, you're going to check for ketones. That's something we made sure to change in the school orders because we know that sometimes you might see that number and want to react. But really, that's not how ketones, they don't build up immediately as soon as you hit that high number. It takes time. So if you see a sustained high for 2 hours, that is the time to check for ketones, or if the patient is ill, regardless of the blood sugar, you're going to check for ketones. You also allow for free use of the bathroom, expecting that they're going to be urinating more often. Of course, water, you can push fluids. You also want to, like we touched on before, consider a pump or site failure. If your patient or your student is on a pump, keep that at the back of your mind. Like, is everything going on or going okay with your pump? You can, if they do have ketones, we're going to be administering insulin outside of the pump using a vial syringe or pen, but we do want to administer the insulin per the care guidelines, which is adjusting for moderate or large ketones, which we'll get into that. If they have moderate or large ketones, we're going to restrict exercise. This is not when we want you to go out and go to PE. No, you're going to have to sit with me for a little bit or stay in the classroom or do some, lower intense activity. We want to be rechecking the blood glucose every 2 to 3 hours and correct if necessary. Contact the parent as needed. And then, like I mentioned earlier, note any patterns. Like if this is a consistent issue after lunch, then maybe we need more for carbs to avoid that. And be in communication with the parent and us if as needed. So what are ketones? Normally the body is using glucose for energy, but when glucose is not available, and not that it's not, not that their blood sugar is not high, or not that the glucose is not there, but it's simply not available because, of course, having diabetes, you need insulin to help bring that glucose into the cell. When it's not available, the body starts breaking down fats for energy, and the result is ketone formation. A small amount of ketones are released through the urine, but most will remain in the blood, and this leads to DKA, diabetic ketoacidosis. DKA is a life-threatening complication of diabetes caused by lack of insulin. It leads to hyperglycemia, ketosis, and metabolic acidosis. This occurs primarily in type 2, although it can happen with type 2, primarily with type 1, it can occur with type 2 under certain stress conditions, which are not very common. Ketoacidosis causes dehydration, just like Dr. Patel said, as it's trying to get rid of that extra glucose, you're losing electrolytes, you're losing fluid volume. It makes the blood more acidic, which could lead to brain swelling, which could lead to comas, which could lead to death. And this is just a visual, although it uses a lot of big words, it just is spelling out, those fat cells are breaking down and causing fatty acids. The liver is trying to help out, and it's trying to convert glycogen to increase the glucose, because it's like, oh, you have no glucose, but the glucose is there, it's just in the bloodstream. So all of this is being dumped in the bloodstream and creating a really dangerous situation. Signs and symptoms of DKA. So we see the top half, those are those first warning signs, which are the same as hyperglycemia. They're needing to urinate more. We're checking for ketones. Maybe they're at the moderate, large stage. But the thirst becomes extreme. The headache is severe. They look dry. Their blood glucose is elevated. And maybe not crazy elevated. Maybe it's in the 300s. It's not reading high. But those are when you really need to start being concerned. And then of course the more serious DKA symptoms would include fruit or sweet scented breath. I've heard it's been described as like juicy fruit, that juicy fruit flavor smell. Very dry mouth, constantly feeling tired, flushed skin, nausea or vomiting, and that's a big one that, just like Dr. Patel says, once we see that, we know that things are progressing in the body and we really want them to be seen immediately. Abdominal pain, the hard to breathe, of course, is a major thing. Fatigue, dry skin, and then just confusion. Has anyone here taken care of a student that started to experience any of these symptoms of DKA? Yes, okay. Anything that stands out that you want to share? No? In the ER, I remember, because DKA can look like different things, and with the difficulty breathing, it can almost seem like is this kid having an asthma attack or something? But I remember one night a patient came in, EMS brings them in and they don't know what's going on. He's having difficulty breathing, he's a bigger kid, he's a teenager. I remember it was very close to Thanksgiving, and the mom, we're getting vitals, we're doing all the things, starting lines, and the mom says, yeah, he's been drinking a lot. Like, I brought a case of water yesterday and he already finished it. And we're talking about a case, 24 bottles of water in 24 hours that he has finished. So that's that extreme thirst that the body is trying to communicate that something's wrong, and it can be missed. A lot of our newly diagnosed patients arrive in DKA because those subtle changes weren't picked up on, and not that it's anybody's fault, but it's just how things happen. These are the sick day guidelines that we hand out to families in clinic, and it just kind of, it's very similar to the school orders where it kind of walks you through, are ketones present? If so, are they moderate? If so, we're gonna multiply that final dose by 1.1, and that's going to give 10% more of insulin. We're going to continue to monitor the blood sugars every 2 to 3 hours, continue to check for ketones with every void, and then you, of course, want them rehydrating with or sugar-free liquids. And large is the same, but we're going to adjust that dose by 1.2 to give 20% more insulin. If they are having elevated sugars, but ketones are not present, we're just gonna keep checking. We're just gonna make sure we don't miss it and keep checking for ketones, keep checking blood sugar. Now, and this is for pumpers. If they're on a pump, the biggest difference is that I mentioned earlier, we wanna consider that this is a pump site failure or a pump malfunction. So if ketones are present and they're moderate or large, we want insulin to be given outside of the pump. We want it to be given with a pen or vial and syringe, so we know they're getting that. Once the ketones are clear, blood sugars return back to normal, then we can resume pump therapy. One thing to note, yes?
When you're resuming the pump therapy, do you still wait the 2 hours after that last correction dose to then start the pump therapy?
That's a good question. I don't think our school orders get into that because that can be a little complicated. But if they're wearing a CGM and it's a closed loop system, the sensor is also picking up that sugar is trending down, and the pump knows, it's not going to attack that as soon as you place it on. So yes, that's fine to replace it. And then this is just an FYI, but ketones can be present without hyperglycemia, and that would be in times of sickness or starvation. Maybe your patient, they're recovering from an illness and they haven't been back to their normal appetite. In that case, our goal is to give insulin to help clear those ketones. So we give small sips of regular soda or sugary beverages every 5 to 10 minutes to bring the glucose up so you can give a correction. And then, of course, it would be that adjusted amount based on the level of ketones. Alright, so a quick question. Ketones are necessary to help your body use sugar, British boy band, a byproduct of fat breakdown, or no big deal and hopefully they'll go away. C, a byproduct of fat breakdown. Alright, when should you consider calling EMS for a student? A student walks into your office with a stomach ache and large ketones. A student's glucose is reading high on the Dexcom. A student is tired and asks to go home. A student has large ketones and complains of difficulty breathing. D, of course. And of course, this is all your judgment. One thing I will point out is I mentioned how sometimes these symptoms can be mistaken for respiratory issues, and so, you know, it has to be made clear if you do call EMS that I'm not concerned about their difficulty breathing as some virus. I'm concerned because they have high blood sugars, they have large ketones, and now they're telling me this and that they need to be seen. And sometimes you have to paint that whole picture for the patient.
And sometimes difficulty breathing isn't, are you having a hard time breathing? It's like, they come into you and they're like, or something to that degree where you're like, they're breathing kind of weird. That should make you go, what's their blood sugar and do they have ketones?
Alright, and Danielle will take it over.
All right, everybody's ready for lunch right before hypoglycemia. Hi, so my name is Danielle. We talked about low blood sugar, so hypo and low, if I think of it that way, and hyper and too much. What are some of the signs that you've all seen treating a low blood sugar? First of all, how many of you have treated a low blood sugar with a student? I would guesstimate most of you, yes? So can you, I'm supposed to be speaking into this microphone. So what kind of symptoms have you all seen that you will never forget that says, ooh, we gotta check his blood sugar? Shaky?
Aggression.
What did you say?
Aggression.
Sometimes aggression, sometimes people get a little
Like irritated.
irritated and unreasonable because there's not enough glucose going to the brain and they need TLC.
I've actually seen the opposite of he get tired. I have a kid that has diabetes, and when he's low, he gets hyper.
Yes, we've seen hyperactivity right before, it's like the body's like, oh my god, we better do something. So yeah, we're out of balance. So we can be sweaty, dizzy, shaky, confused. Maybe your teenagers look like they've been in the bathroom consuming something, but they just have a low blood sugar. They're hungry, they're weak, they can be tired. I've had children say my legs don't work when I'm low. Headaches are common in the low and high, and nervous or upset. Sometimes your body knows there's something is off and you get a little nervous about that. So, and some of the things are not listed here, so that we're not gonna see every single sign, like hyperactivity. Questions about the signs of lows? Okay. So a low, I didn't say on the previous slide, is 70 or lower. That's when we start worrying about treating a low blood sugar. If they're 75, it's about lunchtime and they feel great, that's okay. If they're 65 and they feel great, well, get them some juice, get them above 70, and then send them on their way. So this can progress to more severe symptoms, including loss of consciousness, seizures, and ultimately death, which is what we're trying to avoid. Causes can include just too much insulin, maybe they didn't eat their entire meal or snack, extra or unplanned physical activity, illness, medicines, stress, or any combination of these. And also I'd like to add, as a person who's been living with diabetes for 41 years, diabetes is a jerk and it does what it wants. So we have to be ready. All right. So what do we do about low blood sugar? Obviously we want to eat something, but we want to eat, does anybody know what we want to eat? Fast-acting carbs I'm hearing. So a fast-acting carb is that, it's probably not chocolate, right? Because chocolate is full of beautiful, tasty fat, which slows down our absorption. So juice, hard candy, jelly bean, Smarties, glucose tabs, glucose gel, regular soda, not diet, all those things can equate to 15 carbs of fast acting. If they're below 50, we actually want you to just go for the 30 and just do it. We'd rather deal with a higher number later that we have to deal with than a child having to be leaving school via 911. So, obviously when we think, we can see the CGM, we're gonna use a CGM because most of these kids are gonna be wearing a CGM, or many I should say. We're gonna verify that that is an accurate number with a finger stick. If you're unable to test, treat it like a low. Of course, we said previously, we don't wanna send a little child with a suspected low on their way to the office or to the nurse alone. We want them to have some supervision because we wanna be there if something happens. The rule of 15. The rule of 15 is just as it appears. You're gonna give 15 carbs, fast-acting carbs. We're gonna hang out for 15 minutes. We're going to recheck. And if it's still low, below 70, then should we treat again with another 15? Everybody? Yes. So if they're about to eat lunch, as I said, they're gonna go to lunch once they get up and going and everything's good, they feel better. If not, they might need a post-low snack that has protein, fat, and carbs. Maybe a little yogurt, maybe a little milk, maybe a peanut butter cracker, cheese and cracker, some combination of that so that they hang out until lunch or until they go home. Another thing I wanted to say on the bottom is the students that are wearing the pump devices, they might not require an entire 15 carbs. Sometimes their parents are gonna say, I'd rather you do somewhere between 5 and 8. And they're gonna be fine, because what happens, as you're gonna see later when Callie presents on the pumps, is, hey, the CGM says I'm 75 and dropping, where you're gonna see that pump is like, hey, you're not getting any insulin, so I want your blood sugar to hang out a little bit more. And when it goes high, you're gonna get more. So that's the reason for that. Any questions about treating lows?
I just get more and more parents really wanting to go on the low end of 5, 8.
Mm-hmm.
Your orders don't say that. You don't say variability. You used to say, the parent can do, but it's not specific to that. And I find that more of a point of contention. When I have a kid with 50, I don't wanna give 8 carbs. I want it to pop out fast, even on a pump. And I'm finding more and more of that situation. What would you suggest?
Well, typically we always default to, hey, the parents can have the final say as the parent of this minor child. But in those cases, there could be a discussion had between everybody, like, well, can we give them 12? That make me feel better. Can we, I need to adhere to my guidelines and you're gonna adhere to yours. Do you have anything to add on that?
There's also a lot more in the new school orders that we just rolled out. Those new school orders have only been going out for like 3 weeks.
Yeah.
So if you have kids that started school at the beginning of the year, they might not have those new school orders. So they're a lot more of that's addressed in that new school
Why I
bundle.
mention it, because I'm not talking about the kid that pops back up. I'm talking about a kid that keeps going down, 50, 60, and I'm not
That's
seeing
scary,
them pop
yeah.
back up. And it's taking 20, 30 minutes. And it's just not a comfortable feeling for the child.
Okay, well, I think handling those things individually per family, involving us, saying, oh, I'm reaching a stalemate with this family. Is there something, can we powwow about this, and maybe we can talk to them and we can talk to you and you can talk to them, and hopefully we reach a final thing that makes everybody very happy. So that's how I would go ahead with that. Anybody else?
In situations where the child becomes unconscious,
Mhm.
I have a student, we don't have a glucagon for him because the parent can't afford it. Is the glucose gel just as reliable? I know it's slow absorbing, but is it enough?
No. Yes and no. So ideally, they can follow commands, they can swallow juice, they can swallow glucose gel, glucose tabs, whatever's available. If they cannot, that is when we go for injectable glucagon or up the nose glucagon, which I will discuss. Because that works fastest. That says, hey, liver, let's take care of this problem and dump all the sugar into the bloodstream right now, and they'll be higher later, but they will live through the day, and that's the end goal.
Yeah. And call 911.
Of course.
Yeah.
Yes, and we're going to that next. Okay, you're next.
Well, I have a question about, we've got orders, those are legal.
Mm-hmm.
And then when a parent is stepping in and saying, no, I want you to do this, I want you to do, that's a quandary, because we have a legal order in front of us.
I mean,
Yeah.
provide a note from the doctor that says parents can
Because any other, that's a good idea, because any other situation, I can't change an order without the input of a physician.
I can definitely hear why you're concerned about that, and I would encourage I think that is where the beauty of a 504 meeting comes in, like, hey, I'm here with your child every day, you're with your child every time that they're not with us, and let's talk about what's happening here at school and how to best handle that, and what I'm capable of doing, and what I'm limited from. So those conversations having with those parents, sometimes parents can be a little difficult, as we know, and sometimes once they have more information, are like, oh, I didn't realize that was the problem. Okay, well, why don't we do this? So ideally, that's what we want to do, is we want to engage them in a conversation and meet them where they're at, as we've said, and create a plan from there. And always, you have our phone number, have the bag, so just keep your bag with you always, so you have our phone number. All right, going forward, yes? Okay.
Oh, I'm sorry. I think sometimes we see the sensors and we're watching the number come up on the sensor and it seems to take a while. And I think a lot of people are just not aware of like a lag. So, if you're really worried, you can check with the nurse there.
Yes, I will definitely talk more about that, but in general, the finger poke is always gonna be more up to date than the CGM. All right, so here's some examples of 15 carbs. 4 ounces or a half a cup of juice, or one of those little baby boxes of juice. 4 glucose tabs is 16 carbs in most cases. 1 tube of glucose gel is typically 15. They're dosed for 15 because we have the rule of 15. That is a standard in diabetes care across the board. Hard candies, I say 15 Skittles because Skittles are typically 1 carb, so it's easy to comp to 15. Sweet tarts, 6 to 8. 2 to 3 tablespoons of honey. Regular soda, 4 to 6 ounces, about a cup, half a can. Here we're saying just one more time, chocolate's not to be used because it's got carbs and or protein, so nuts, things like that. That slows things down. We just want to get that sugar in ASAP. Everybody comfortable with that? All right. All right. Ooh, a question. Something interactive. What do you guys think? Jackson's 5. He lays his head on his desk and he starts to cry. And he also has diabetes. So what do we want to do for Jackson? Should we just be like, drink some milk, Jackson? Or should we test his sugar? Or should we give him some insulin without knowing what his blood sugar is? Or should we send Jackson to the nurse's office alone to test? Yes, we should just test his blood sugar and go from there. All right, so, oh no, his blood sugar is 64. What's the best course of action for Jackson? Do we want him to eat his lunch early? Do we want him to have a small box of juice and then test again in 5 minutes? We want to give him 15 grams of chocolate and test again in 15 minutes? Or do we want to give him 15 carbs or 4 ounces of juice and then test again in 15 minutes? You guys are really good at this. All right, almost time for lunch. Okay, so the post-recovery snacks, as we discussed a little bit earlier, We're gonna follow that rule of 15. Once we get above, on top of 70, if they're about to eat lunch, they're just gonna go to lunch. But if it's gonna be an hour or two, they might need a smaller snack, cheese and crackers, apple slices and peanut butter. Milk and yogurt are really great sources of a small amount of carbs with some fat and some protein. That'll kind of just hang out with them for a bit.
Just to clarify, the post snack, we're not correcting that?
No, we're not gonna correct it. We're gonna try to keep like
Okay.
5 to 10 carbs-ish.
Yeah,
Maybe lower if their carb ratio is lower.
yeah,
But we just want them to have something to
Yeah.
kind of
I just wanted to like.
go get through the
clarify.
day. And I always use this. It doesn't matter who I'm talking to. Okay. There we go. Severe hypos, we talked briefly about that earlier. When we're 50 or less, just go for the rule of 30, but use the 15 minutes. So two correction, so 15 twice, and then check again in 15 minutes. And hopefully they pop right back up, and if they don't, if we're drinking the juice and they're going 40, and you know, we're starting to get really concerned here. As long as they can swallow, they can follow commands, they can eat or drink, they're conscious, they're looking at me, they're making eye contact, they're good. Once they pass out, they have a seizure, belligerence or aggression, as someone pointed out, they start saying, I'm not low, and all of a sudden, this kid's 17, he's bigger than me, I'm kind of concerned, you know. That is when we have to do something else, where we're not gonna be able to get them to drink anymore, and we're gonna give the glucagon, then we're gonna call 911, well, we're gonna turn them to their side maybe, and then call 911. So as long as those happen around the same time, we're good. Just because once we give the glucagon, we might vomit. So different glucagons. Oh, no, I'm getting ahead of myself. We're gonna keep a level head. We're gonna place them on his side. We're gonna keep his airway open. We're gonna prepare or inject the glucagon. We're never gonna put anything in the mouth. We're gonna call 911 and contact the parent or guardian, of course. Stay with child until help arrives. We might need a team of people to do all this too. We might need, I'm gonna give the glucagon, you call the parent, or you call 911. So have a plan for that. And always stay with the child until someone comes to intervene. All right. Glucagon, life-saving hormone that raises blood glucose levels by stimulating the liver to just dump all the sugar that it's holding on to. It's a treatment for severe lows that would be, as we described, they can't swallow or follow directions anymore. Administered by any individual, and you probably need to be trained or get comfortable. We do have some of the reps here today that you'll be able to talk to and see the products, and we'll look at them with you if you have any questions about that. They're typically stored at room temperature. Expiration date should be monitored. They're individual. They're like usually 1 or 2 years from the time the parent picks them up. And after using, you're just going to dispose of any unused product. All right, so let's go into the individuals. This is the oldest kind, the red box. It's probably the kind that your child has if they don't have insurance or they can't get covered. That one we're going to, it's a whole kit, and it's a little intimidating for someone who has not been to medical type schooling, because you have to take the liquid out of the syringe, put it into the little vial, mix it up, and then drop back. And then you give it. We can talk individually about that. If you have any questions about that, if you're concerned about how to give it, let us know. Typically those are given intramuscularly, so on the top of the leg is a popular area to give it. All right, next. Vaccine. Now this one is going to be the go-to for all of the access plans effective 10/1 of this year. This is the easiest one to use. It doesn't require, even if the child were not breathing, the blood vessels that are in the nose will suck up that medication, tell the liver to dump the glucose, and voila, we call 911, they're on their side. It becomes a fun family story. Maybe not so fun, but that's a really great one, and that's approved in ages 1 and up. Just a little disclaimer, you might have a child someday if you're more that you hear of that's diagnosed before age 1. If we prescribe it, we've decided, this is the best possible option for them. But if you have any questions, always give a call to us. As you can see it, they take it out, they put it right here, and they just dispense it into the nose. Questions about vaccine? Alright. Gvoke, that was previously the most popular one. That one's a really great option too, because it's just preloaded and there's not, as long as you're injecting it, get the belly, the arm, anywhere where insulin goes. Approved at age 1 and older. You can see that it's according to their weight and age and how we decide if they're going to get a 0.5 milligram or a whole milligram. So if you have a child who's got a 0.5 milligram and they're 12 and now they're 120 pounds, and we don't see that, let us know. And then Zegalogue is less common. It depends on the insurance in most cases. This one's only approved at ages 6 and up. And that's a preloaded pen. All right. Any other questions about glucagon? All right, great. Special situations, very briefly, field trips, overnight trips, competitions. We have to plan for these things. Often this is on the parents, but you might be involved too. Planning and preparing the student and parent for all these extra things is important. Celebrations, knowing the carb count of foods, knowing that you can use any of those things that Shannon went over. For Calorie King is a favorite of mine. Parents can be a resource, like how much do you, as far as if they bring cupcakes, did you figure out how many carbs is in that? Well, most of them probably haven't, but maybe. But otherwise, you can just look at Calorie King and say, a small cupcake is usually this much, and you can be pretty good, pretty close with that. And you can Google it. If it's, hey, they brought Krispy Kreme donuts, you can Google how many carbs in a Krispy Kreme, this flavor, and it'll tell you. So that's pretty fabulous. We have new situations that we never had when I was in school of lockdown. Being prepared for a lockdown is something probably you've all discussed at your jobs. And with diabetes, that just adds an extra layer of concern. Of course, if we're in a lockdown situation and it's very unsafe, we might want to figure out how are we going to silence the alarms? And who's going to watch the Dexcom during this? Who's going to be does the substitute teacher know? Do all the teachers that care for this child know that this might require a little bit of extra attention? So those are good conversations to have with your parents and coworkers. Questions about that? All right. So of course we're going to keep a bag of emergency supplies, and these are the ones that we list in our school orders, but these are the ones that we want them to all have in their go bag. And I think that wraps me up. Questions?
Yeah, we have time dedicated at the end of the presentation for questions, so apologies if you have questions, but it is time for lunch, and before you all rush off to lunch, I just wanted to explain that the lunch is on that half of the building. The recs are directly behind us and potentially on the side of us. You all have a scavenger hunt form. There's not a prize for completing the scavenger hunt. The scavenger hunt is more for your benefit. So the individual pump companies are there. They have their pumps, play with them, ask them questions. We have a presentation about pumps afterwards, but it's very generalized. So if you have specific questions about individual pumps, I really encourage you to go talk to those representatives. And that will be both over the lunch hour and during the rep time. So if you could just plan to be back in this room at 1 o'clock, because that is when the lunch hour / vendor fair is over, we would really appreciate it. Thank you so much.